This PowerPoint is going to focus on the concept of immunity. The exemplar is rheumatoid arthritis. So rheumatoid arthritis is a rheumatic disorder because it affects the connective tissue, the joints, muscles, bones, and it can affect other organs within the body. It is autoimmune in nature and has an inflammatory process that occurs. Typically with autoimmune disease, there is some type of external trigger or exposure, and that stimulates the immune system for an inflammatory process to start occurring. Both T and B cells are linked to the inflammatory process. And as the inflammatory process starts to occur, there's antibody and antigen complexes that are made from the immune system. And these complexes start to build up and stay within the joints. So if you think about the A and P of the joints, there's synovial fluid and a synovial lining around the joint. All of those complexes, the antibody antigen complexes, get stuck within that joint space. So overall, that leads to a synovitis. So itis, it's an inflammation. So this uncontrolled inflammation occurs within that synovium. And over time, that leads to the cartilage and the bone destruction that occurs. That inflammatory process happens because there's leukotrienes and prostaglandins, which are inflammatory chemicals that stimulate the signs and symptoms of inflammation. And they increase that inflammatory process. And as all of that inflammatory process occurs, it starts to break down the collagen. The collagen is what is in the cartilage. The cartilage within the joint acts like a shock absorber between the bones. So as that collagen gets broken down because of this inflammatory process, it breaks down that collagen in the cartilage, and then it can start to damage the bone. And over time, a pannus forms. A pannus is like extra fibrous tissue within that synovial tissue, and it causes that extra tissue sticks to the cartilage within that joint. So this is what contributes to a lot of the signs and symptoms that we see with like the decreased mobility, and then the inflammatory process is what's causing some of the other signs and symptoms. Typically, patients will first start to have joint pain. Some of the key things for us to assess with that joint pain is which joints are affected, and is it unilateral or is it bilateral? So with rheumatoid arthritis, usually it's the small joints first. The hands, fingers, wrists tend to be the first areas where symptoms occur. And with rheumatoid arthritis, it tends to be symmetrical, so it's bilateral. This will be key when we talk about some other different types of arthritis that are not bilateral, that those tend to be just unilateral. So rheumatoid, small joints, and bilaterally affected. There's stiffness that occurs within those joints. The stiffness, especially in the morning, usually lasts over 30 or 60 minutes. So they really have to kind of work out that stiffness before they have full function of those joints. Think inflammatory process. So there's likely swelling, tenderness of those joints if you palpate them. They may feel soft or even look a little bit puffy from that inflammation that's occurring. Patients may have a low-grade temperature because it's an inflammatory process and the immune system response. Deformities of joints will occur over time as the disease progresses. Some of those deformities that can occur are boutonniere deformities, swan neck, and ulnar deviation. Rheumatoid nodules that occur like in the subcutaneous tissue or near the joints can be seen as well. Outside of the joints, patients may have a general feeling of fatigue, can have an overall feeling of malaise. It can affect other joints as it progresses. So it usually starts like in those small joints of the hands. And then as the disease process progresses, they can develop rheumatoid arthritis in other joints throughout the body. In the large joint, shoulders, knees, hips, and even into the spine. In rare instances, it can even occur in the jaw. And then as the disease continues to progress, it starts to affect other body systems and not just the joints, which we're going to talk about in just a few minutes. So for diagnostic criteria, there is no one single diagnostic tool that's 100% definitive for rheumatoid arthritis. It's a whole set of criteria in addition to their overall assessment. So we just did the assessment, looking at what joints were affected, how many of them, how long they've had the symptoms. The other criteria from the American College of Rheumatology is in this diagram on this page. Lab work that is looked at. Specific to rheumatoid arthritis, the rheumatoid factor is looked at. It is a type of autoantibody that's made by the immune system that causes it to target and attack itself. So the results for a rheumatoid factor are either positive or negative. It is not always 100% accurate. Like, they will test for a rheumatoid factor. About 20% of patients have rheumatoid arthritis, but they have a negative rheumatoid factor. And on the flip side of that, about 5 to 10% of healthy patients have a positive rheumatoid factor and don't have the disease. So it's not always 100%, but it's definitely looked at. The ACPA, or anti-citrullinated peptide antibody, or it's sometimes also referred to as anti-CCP, is another autoantibody that's made by the immune system. And the same thing, it's tested. It is highly specific for rheumatoid arthritis, but it can also be positive in other autoimmune disorders. CRP, C-reactive protein, and ESR, erythrocyte sedimentation rate, are the other two reactants that are looked at for inflammatory process. Again, they're just for general inflammation. They're not only specific to rheumatoid arthritis, but they are part of that diagnostic criteria. Some other things that may be looked at, a CBC, because they're looking for increased white blood cell count because there is inflammation present. Hemoglobin and hematocrit, it can be decreased due to the fatigue, which could be causing the fatigue that the patients may be experiencing. There is an anemia of chronic disease that occurs. X-rays may be done. The X-rays are really done more to follow the disease process, because an initial X-ray they will do, and then over the course of the disease, they look for narrowing of the joint space. So it's not necessarily going to diagnose rheumatoid as much as keep an eye on how much that joint space narrows. Joint aspiration can be done. It can be somewhat therapeutic as well as diagnostic, but normal joint aspiration, so the synovial fluid is normally a clear, pale, and thin fluid. Whereas if there is an inflammatory process within the joint, then it's likely to be milky or white in color and maybe be a little bit thick because it has all those extra white blood cells in it. If there is a lot of excess fluid in the joint, then when they do that aspiration, if they remove it, then it may help with some of the symptoms that are occurring. Some of the treatment goals for rheumatoid arthritis are to suppress that inflammatory process. So it's an autoimmune disorder, so it's a chronic, lifelong condition. There is not a cure for it. So it's really a matter of maintaining as much as possible. Statistically, almost 40% of patients who are diagnosed with rheumatoid arthritis become disabled within 10 years of that diagnosis. So the mobility and the functioning that a patient has at diagnosis is probably around the best that it's going to be. And our goal is to keep it there and prevent it from getting any worse. So our goals, manage the pain and the symptoms, help maintain or improve the mobility if possible, and the functioning. Patient education in regards to disease process, that it is chronic, lifelong. Educate on medications, on exercise, physical therapy, occupational therapy, what to expect as the disease progresses. And then to reinforce how important the treatment plan is and adhering to that treatment plan, the patient's going to likely be prescribed medications to help manage the inflammatory process. So making sure that there's follow through on that treatment plan and taking those medications. Pharmacologically, treatment options. NSAIDs can be used, non-steroidal anti-inflammatory drugs. Are they going to do anything for the disease process that's occurring? No, they're just going to treat the symptoms. They're going to help to decrease the inflammation, help with some of the pain, but they're not going to do anything for the overall immune response. They can be beneficial at first because a lot of the other medications that are used may take a little bit of time before they start working. So the NSAIDs can help treat those symptoms at that point. Some common ones, COX-2 inhibitors, the Celebrex can be taken orally. Voltaren, they make a over-the-counter version of the topical cream that can be applied directly to the joints. Again, just to help with those symptoms, the pain and inflammation that's occurring. Remember your side effects for NSAIDs. GI upset is big for oral. That's why the COX-2 are used, because they help have some protective benefits to the GI tract. Other things to watch for with NSAIDs, there's a risk of fluid retention. Keep an eye on renal function, a risk of cardiac events. The big category of meds that are used long-term to treat rheumatoid arthritis and a lot of other autoimmune conditions are DMARDs, disease-modifying anti-rheumatic drugs. In order to help maintain functioning and to slow the progression of the disease, it is best if a patient starts taking a DMARD within 12 weeks of that symptom onset and or diagnosis. The sooner they start them, the better their long-term functioning is going to be. So these medications under the DMARDs, there's some subcategories, but they work specifically on the immune system. So they target the actual immune process that's occurring to help decrease the inflammation. Kind of the gold standard under the DMARDs, methotrexate. It is an immunosuppressant drug, so it helps to decrease that immune response. But it does take a few weeks before it starts working, about 6 weeks. But in long-term studies, the earlier a patient starts taking the methotrexate, the better their long-term functioning is. Some key things to watch for with methotrexate. Because it's an immunosuppressant, it was originally designed as an anti-neoplastic, so like a chemo med, is it suppresses the immune system and the production of white blood cells, red blood cells, and platelets can all be decreased. So keeping an eye on those. There's a significant increased risk for infection. So making sure that patients are aware to avoid large crowds, watch for any signs of infection, because if they're taking a medication that decreases the immune response, then their body's not going to be able to react. So if they start to see signs of an infection, then it usually indicates there's a pretty significant infection going on. Because women are highest risk to develop rheumatoid arthritis, if it's a younger woman, they cannot take methotrexate if they are pregnant or trying to get pregnant. It has teratogenic effects. Other meds in the DMARD class, hydroxychloroquine, which is Plaquenil. It is classed as an anti-malarial medication. It also works by decreasing the immune response. Big things to watch for, vision changes, especially blurred vision. And it is not given to patients who have a history of cardiac disease, like methotrexate, because it decreases that immune response. The risk for infection is high. Biologics are one of those subcategories under the DMARD group. Those typically work off of TNF, so tumor necrosis factor is what a lot of those meds are classified as. Some key things with the biologics, because they work to suppress the immune system and how they work on the immune system specifically, patients that are getting ready to take a biologic need to have a TB test done beforehand to make sure that they don't have latent TB. Because if they do have latent TB and then they start taking a biologic, that latent TB can actually turn into active tuberculosis. Some common examples of biologics are etanercept, which is Enbrel, adalimumab, which is Humira. Both of those are given subcutaneously, so teaching a patient how to self-administer them. Infliximab, which is Remicade. It is given by IV infusion. Remember, those MAB drugs work on the immune system. I think we've talked about them in previous classes. There is a table in your textbook that lists out some of the different biologic meds. Again, with any of them, because they are working to suppress the immune system, the risk for infection is high. So making sure to teach patients to watch out for signs of a fever. Remember, a fever is the body's normal response to infection or an inflammatory process. So if you or I get sick, you develop a fever because that's your immune system responding and trying to fight off something. So if we're talking about a patient who has an autoimmune disorder and they're taking medication that suppresses the immune system, if they start to develop a fever, a low-grade fever is really important to watch for, because that means their immune system is working that much harder to try to produce that fever. So we worry more if these patients start to get a temp 100.4, 100.5, more low grade, maybe even 100, that there's something going on infectious for them. And then the last group of meds that can be used are steroids. Steroids are not used really long-term anymore, unless it's a specific patient that is tried other DMARD medications and biologics and they don't work, or they have some type of reaction to them. It's pretty rare that you're going to see somebody on long-term steroids just because the side effects of long-term steroids are so severe. Sometimes if there's an acute exacerbation, then the patient may take IV steroids or even oral steroids for a short time to help to suppress that inflammation. Some of the nursing care to focus on: education, educating them about their meds, signs and symptoms to watch for in relation to side effects of meds, how to take their meds, if it's a sub-Q injection, how to self-administer it, what they can do to help treat some of the signs and symptoms. So heat and cold can be effective. Heat, so moist heat can be beneficial to help loosen and improve the mobility in stiff joints. The cold may be beneficial if there's an acute inflammation. Complementary therapies, some patients use acupuncture or guided imagery to help with their pain. Rest periods, if they're exhibiting signs of fatigue. If they do have anemia, then they may be on like a folic acid supplement. There are some anti-inflammatory diets that some patients find helpful. If the patient is obese, then by losing weight, it may help, especially if larger joints are affected. As the disease progresses, they may have physical therapy or occupational therapy. The earlier you start it, the more you're going to keep their mobility up. Exercise. Exercise can be a variety of different things depending on what the patient can do. Water exercises tend to be good for joints and joint mobility. It could be walking, it could be yoga, anything to help strengthen. As the disease continues, assistance for ADLs may be needed. Remember to think about if it's hands that are really affected, think about how much you use your hands. If your joints, if you're not able to move them, try to promote independence as much as possible. Steroid injections into the joint can be used but they're not really a long-term. They'll help with the pain and inflammation, but they're not done a whole lot for rheumatoid arthritis. That if we can do something to affect that overall immune response, then that tends to be more beneficial. Educating the patients also on some of the signs and symptoms that can occur that are not related to the joint specifically. So Raynaud's, which is a vasospasm that occurs at the vessels. It causes the hands to be white or even bluish in color, can occur frequently with autoimmune diseases. A lot of other itises can occur, pleuritis, in regards to the pleural space, vasculitis, so the vessels become inflamed and can even become ischemic and can lead to cardiac disease. Sojourns, which is like a dry mouth and dry eyes, that can also occur with a lot of autoimmune. So just making sure the patient is aware that these can occur. And also some of the joint deformities that can occur. I think there's also some pictures in your textbook of some of those as the disease progresses, kind of a what to expect. If you have any questions related to the content, then bring them to class when we meet and we will discuss it. And I have an unfolding rheumatoid arthritis case study that we can go through.